Interpretation of complete blood count. When you get a blood count report, you see multiple parameters and you must have an idea that what is the significance of these different parameters. In this video, we are going to see about the red cell lines. We have already discussed the working of anemia and polycythemia. In this video, this is going to be a small video on the interpretation in case we get a patient who's got anemia, because polycythemia is generally a straightforward sort of interpretation. It does not require a lot of thinking, but in patients who've got anemia, you may require multiple parameters to be analyzed to make a conclusion that what is the possible underlying lesion and what is the cause of this anemia. Now, when the red cell line, keep in mind one thing: all interpretations should be done in the light of peripheral film, because the peripheral film manually seen by a hematologist gives a far better picture of anemia rather than just relying on the red cell indices or whatever is written on the reports generated by the automated machines. Now, you see, there are measured parameters and there are calculated parameters when you see the red cell lines. In the measured parameter, you see hemoglobin, it is in grams per deciliter. You got hematocrit, which is in percentage of RBCs in the blood. It can also be a measured value or a calculated value. It can be both ways. And then we have got RBCs, that is the number of RBCs per unit volume of blood. These are measured values. Then we've got calculated parameters like MC, which tells us about the size of the cell, and then you get the MCH, which tells us about the hemoglobinization of the RBC, and then MCHC tells us about the average concentration of hemoglobin within an RBC, and then finally we've got a red cell distribution width, which tells us about the variation in the size of the RBCs, that there are multiple populations available in the circulation. They may be small RBCs and they may be large RBCs. So this is red cell distribution width. Now we are going to see how to see these parameters when you get a CBC and how to draw a meaningful conclusion out of this. Now, when you are examining a CBC, you see there's a rule of 3. In healthy individuals, the hemoglobin is roughly 3 times the RBC count expressed in millions per microliter, and the hematocrit is roughly 3 times the hemoglobin. This is a general rule. This is not a very hard and fast rule, but in a normal healthy adult male, this is usually seen that the hemoglobin is 3 times the RBC count and hematocrit is 3 times the hemoglobin. If there is a deviation, for example, you see there is a disproportionately large number of RBCs when you compare it with the hemoglobin, must always consider this patient may be having thalassemia trait. The RBC number is far more than the hemoglobin in this patient. And if the RBC percentage is low, this may be because of the clumping of the RBC. So these are two things which, when you first see the CBC, should see, are the RBCs and hemoglobin proportionate, or hematocrit and RBC number are proportionate or not. And then MCV, if it is low, then go for the red cell distribution width. How is the red cell distribution width? If the red cell distribution width is high, that means there is a scatter of RBC sizes. There's small and large RBCs in the circulation. This is seen in iron deficiency anemia, and this MCHC is generally low. Then you can also see a high red cell distribution width in anemia of chronic disease, in anemia of renal failure, there is low MCHC, and in sideroblastic anemia, MCHC is again low and there is a high red cell distribution width. And then if you got low MCV with a normal red cell distribution width, this can be caused by beta thalassemia itself or beta thalassemia trait. The RBCs are large in number, but generally they are small and they are of a uniform size, while in iron deficiency anemia, the RBC number is not very large, but they are of different size population in the RBC, so red cell distribution width is high. If you got a high MCV, again see the red cell distribution width. If the red cell distribution width is high, this is generally seen in megaloblastic anemia, the B12 or folic acid deficiency anemia. The MCH is high in these, the MCHC is generally normal. And then if the red cell distribution width is normal, this may be seen in patients who've got cirrhosis, those who are alcoholics, those who've got hypothyroidism, those who've got aplastic anemia. Patients with aplastic anemia may have a normal MCV, and some of them may have a high MCV when the bone marrow is trying to compensate and um, immature forms are poured into the circulation. They may have a higher MCV. Then you got MDS and spherocytosis. It can have a normal red cell distribution width with high MCV. The MCHC in this is also high. And then you see patients who got complete blood count with a normal MCV. Again, look at the red cell distribution width. If it is high, this could be seen in early cases of iron deficiency anemia, folic acid deficiency anemia, or beta 12 deficiency anemia. They can also be seen in clear dimorphic picture in patients who've got dual deficiency. Then hemolytic anemias, because there may be large number of retics coming to the circulation, they may have a high MCV. Patient who got MDS, that's a myelodysplastic syndrome, they can have a normal MCV with high red cell distribution width. Sickle cell disease, in sickle cell disease, MCHC is high. And then patients who got chronic liver disease, they may also show in some patients normal MCV with high red cell distribution width. And then hemorrhage. Now, in hemorrhage, you may have high red cell distribution width if the reticulocytes are started coming into the circulation. Otherwise, this anemia is usually normocytic anemia with normal red cell distribution width. So if the red cell distribution width along with MCV is normal, this may be present in anemia of chronic disease, blood loss anemia, that immediately if you check the hemoglobin and CBC, you find that the hemoglobin may be nearly normal and the MCV is normal and red cell distribution width is also normal. It is after some time when the reticulocytes start coming into the circulation, the red cell distribution width starts getting higher and higher. Then in patients who got hemolytic anemia may have high MCHC, and then patients with aplastic anemia may have normal MCV with the normal red cell distribution width. As I told, some of these may also have high MCV. Then MDS can present in multiple ways, and if you're not able to understand the reason of anemia, especially in older people with high ESR, MDS should be a possibility which should be considered.